Good afternoon, everyone. I am Meerab Shahid.
And I am Haja Nawazish Ali. We welcome you all to the musculoskeletal workshop on behalf of the Pakistan Society for Rheumatology. Before we begin, I would like to make a few announcements. We'll be keeping the lectures short so each delegate here can participate in the practical demonstrations. Please take note that all delegates have been divided into 5 groups that are being displayed on the screen in front of you. For further assistance, your names have also been displayed at your respective stations. In case of any queries, our ushers will be there to assist you. I'll be calling out your names for each group.
Group 1, Dr. Saeed Mahfouz Alam, Dr. Hamza Alam, Dr. Avinash Punchi, Dr. Sadiq Rahman, Dr. Saeed Nazir Aga, Dr. Ataur Rahman, Dr. Shahida Parveen, Dr. Yasir Qamar, Dr. Shuja Majid, and Dr. Syed Kamal Hussain.
For Group 2, we have Dr. Bilal Azim Bhatt, Fizan Ahmed Qureshi, Dr. Ziaul Haq, Dr. Numan Zafar, Dr. Lubna Abbasi, Munir Sadiq, Dr. Saman Ali, Dr. Tahira Parveen Umar, Dr. Arif. Kindly see your names on the screen and note it down. Or take a picture of the screen.
We trust you've had a refreshing break and are ready to continue with focus. We now gather for the musculoskeletal ultrasound workshop, one of the most practical sessions of PSR review course. The workshop highlights the growing role of musculoskeletal ultrasound in clinical evaluation and real-time decision-making for rheumatologists.
We would like to thank Dr. Sajid Ghaffar from Biomed for their valuable contributions in making this workshop run smoothly.
To begin our musculoskeletal ultrasound workshop, we are pleased to welcome Dr. Maaz Ali Abbasi, consultant rheumatologist at University College London Hospital, NHS Foundation Trust, UK.
Dr. Abbasi is a dedicated clinician with extensive experience in both clinical rheumatology and musculoskeletal imaging, contributing actively to education and training in this field. He will be conducting today's session titled Basics of MSK Ultrasound Workshop for Rheumatologists. This foundational session is designed to strengthen core ultrasound skills that are invaluable for practicing rheumatologists in everyday clinical settings. Please join me in welcoming Dr. Maaz Ali Abbasi.
Good afternoon, everyone. Bismillahirrahmanirrahim. Good afternoon. Thank you for the promotion to being a consultant rheumatologist. I'll demote myself. I'm a lowly radiologist. I have an expertise in musculoskeletal imaging, and that's why I come back to speak to you. It's always an absolute pleasure to come back to Pakistan. It really feels like coming home every time I come. Meeting lots of friends. So I hope this lecture is useful for you. And the purpose of this lecture is not to make you into a radiologist, but it is to give you an idea of some of the physics principles behind ultrasound, which then will help you to set your machine up to optimize your imaging. I've been only given 10 minutes, so Dr. Babur has given me dirty looks if I overrun. So I'm going to whiz through the first part. But essentially, ultrasound is based on the piezoelectric effect. And this essentially means that there are certain materials that when you pass a current through them, they will expand and contract, and that will emit a sound wave. And if you have an alternating current, they will expand and contract in the same, contract with the same frequency. In addition, this can also act as a transducer in terms of receiving the signal. And the frequency with which the compressions pass a fixed point is the same as the frequency or vibrations that the transducer vibrates and is directly related to the voltage that's applied. So this is the basic layout of your ultrasound probe. You have here, if I have my arrow, it is here. So you have, this is the piezoelectric disc, which is usually made out of something called lead, zirconate, titanate. There are different materials, but most probes will be made out of this. It will have a plastic plate, which is the bit you'll see on your probe. Behind it is a resin, which has perfect transmission of the sound waves, so that no sound is lost. And then around it is a installation that goes all the way around, which is the plastic bit that you hold. So going through very quickly, I'm going to whiz through this bit because the next bit is probably more important. But essentially, here are some basic principles. Axial resolution is the ability to distinguish between two structures that are directly next to each other in the same plane, whereas lateral resolution, and that is equal to half the spatial pulse length. Spatial pulse length is the product of the number of cycles in a pulse of ultrasound and the wavelength. And the wavelength is what's determined by the frequency of the transducer. Why is any of that important? It all sounds like gobbledygook. Well, this is the main reason, because essentially what this is showing is that probes that have high frequency will have a longer near zone. Now, the near zone is where the beam is parallel, all the sound waves are running in parallel. When they pass beyond that point, they will diverge, and your sound waves, the information that you'll receive from here will be distorted, and you'll get lots of scatter information which will distort your image. So the best image you will get will be in this near zone. And having a high frequency probe has two advantages. It gives you better lateral resolution, and it will give you more of a near zone. The higher the frequency, the better the near zone. In addition, you can focus that focal zone, so it doesn't have to be exactly here. So you can actually make adjustments, a bit like a camera lens, and make your focal zone more focused just into this particular area. So if there's a structure that you want to see in this particular area, you can focus the sound waves. Now, acoustic impedance is a really important principle, because it is the difference between the acoustic impedance of different materials that determines how much sound wave makes it back to the probe. So acoustic impedance is a principle which is that it's is based on velocity of sound waves through various materials, and these are fixed, that you can see through soft tissue, air, fat, and bone, and then the density of that material. And what determines what goes through and what gets reflected back is the differences in the acoustic impedance. Therefore, the greater the difference in acoustic impedance, the greater the value of R. Okay? So that's the greater the value of R. It's dependent on how much difference there is. Now, you want maximum transmission between your backing plate and the zirconium plate underneath it. So that should have Z1 should equal Z2. So that is a perfect transmission of sound either way. But when we reach different structures, you will have differential amounts of sound waves going through and how many that are being reflected back. And that is what will allow you to distinguish between the different soft tissue types. Now, here's the last bit of the physics that you just need to pay attention to. So the reflection coefficient of PZT in soft tissue is 80%, so only 20% of the sound waves are reflected. But adding a matching plate, which is in between the soft tissue and the plastic, will improve the transmission of the sound waves from the zirconium plate. Adding in a coupling agent like gel or blood or pus or anything that's between the probe and the skin will mean that there is no gas between the probe. That's actually the only purpose of the gel, is to eliminate the gas. So you don't need to cover your patients with gel. You just need to be able to eliminate the gas between the plate and the skin, and that will ensure better transmission of the sound waves. Now, your basic ultrasound setup, I won't bore you in this bit, but this is how I scan rheumatology patients generally, whether it be hands or elbows, upper limb things. Shoulders are slightly different, and ankles obviously very different. But generally speaking, if you're doing hands, this is how I set myself up. This is the basic console of most ultrasound machines. Even the ones we have today will have something similar to this. And you can essentially have most of these machines are now relatively automated, so they'll have lots of presets, things that you can press buttons of, but actually you can adjust most things like you can with most cameras these days. And this is what the display will be on the actual monitor. I tend to hold the probe right close to the tip. This means that I have good tactile feedback about where the probe is, where the patient is, where their finger is, etc., etc. And you can lose focus of that if you hold the grip, if you grip the probe a bit further up, and you can lose fine touch, fine motor skills if you hold it too far back. But this is essentially the bit that you really need to remember. And this is how you optimize your image, and this is a cycle. So when things aren't going right, always revert back to this. And I have to say, even 15 years on, I still use the same system now than I did before, and I still train it to my registrars. I find this to be a very, very useful way. And the first part of that is make sure you've got the right probe. Choosing the right probe. So we talked about having a linear probe, because the curvilinear probe, the whole beam comes from the divergent probe. So that will give you bad quality images. It will give you scatter, lots and lots of scatter. The advantage of a curvilinear probe is it gives you depth, but you will not get the fine detail that you get in a linear probe. So choose a linear probe and go with the higher frequency that you can get. So that's the first thing. These are the high frequency probes. They often have a number on them, 18, 16. That will tell you what the operating frequency of that probe is. Now, the difference is that if you use this is a 16 megahertz probe. If we have the lights down, can we have the lights down a smidge? If we had the lights down a bit, it would help you to see the images. But what you will see is that on 18 megahertz, what you have to concentrate is the detail of the cortex. And you will see that on a higher frequency probe, the image will be higher resolution than it would be with a lower frequency probe. The next thing is preset. Now, many of these machines will come with presets already installed. It will say finger, shoulder, elbow. When you buy your machine, whenever you do buy them, spend some time with your application specialist to get the images exactly like you like them. They will alter them for you and then they will save it for you. If you are someone who's a whiz, who knows how to play around with it, then it's less of an issue. But if you don't, then work with your specialist. So I actually have my own preset, which you can see has got my name next to it. The next thing is that if you look at the presets, look at the difference. So this is one that's been done on a thyroid preset, the one at the top. Again, if we have the lights down, it would really help. You'll see the difference that on a thyroid preset, everything is very processed and it will be blended. Whereas on a musculoskeletal, we have a much sharper algorithm and therefore the images will be much sharper. You'll get much better cortical detail than you would do if you use the wrong preset. The next thing is contact. We talked about contact, and there are several tactics, and when it comes to the hands and small joints, it is important not to apply too much pressure, particularly if you're going to do power Doppler, because you will occlude the microvessels, and some of the newer technologies that have things like SMI or superb microvascular imaging, if you apply too much pressure, you will occlude the vessels and you will miss the hyperemia that you're looking for. The next thing is gain. So you can change the gain. You can see gain is just about how much of the, it's basically, it's a physics principle that allows you to have a brighter image effectively. So you can play around with the gain. The next is depth. If you have too much useless information, like here, the machine is trying its best to process images from back here, but this is wasting a lot of computing power. What is better is to eliminate this area and reduce your depth so that you focus the image here. You can see that the resolution of the image improves when you reduce the depth. In addition, finally, we talked about focus. I showed you how you can focus the sound beams. When you focus them, you can see that at this point, you look at the resolution of this synovium, it doesn't project so well. But if you look here, you get a much higher resolution image where you can actually see the articular cartilage. You can see a tiny deposition of calcium. You wouldn't have seen that up here on this image here, but you can on the image that's got the better focus on it. And you can see the differences. Here, the focus is beyond the image. Here, now the focus is at the level of what you're trying to look at. And finally is anisotropy. Now, anisotropy occurs whenever you have linear probes. If you have sound waves being emitted and they're coming back in a parallel structure, then no problem. All the sound waves come back to your plate. But if you have your probe at an angle to the body part you're looking at, and that is a real problem when it comes to limbs, when you're looking at fingers, hips, whatever, you will need to keep adjusting. Then what happens is some of the sound waves are lost. So they go to the structure, but as they're reflected, they go off the probe. The probe will then, the machine will then interpret that as a loss of image signal. And so it will show this area as dark or black because there's no signal there. And this is exactly what you see here. So if you look at this one where we're looking at the extensor tendons, the probe is being held at an angle. You can see all of these either look like very tendinopathic tendons or they look like potentially tendon tears, but actually none of those are true. If you just adjust your probe position, the tendons come into view again, and that is a principle called anisotropy. And so it's very important to eliminate that. And you continually go around. So if your image is still bad, and you've adjusted for all of these things, you need to change your probe. So if you're going at a high frequency probe, say 15 megahertz, you need to go one down to 12 megahertz. If it's still bad, go down further to a 9 megahertz probe. And you keep going until you get the right probe, the right preset, the right contact, gain, depth, focus, anisotropy. And you keep going around this cycle until you get the right images. I think that's everything I wanted to say. And I think, am I in my 10 minutes? Just about? Okay. Thank you.
Thank you, Dr. Abbasi, for your insightful presentation.
Our next speaker is Dr. Babur Salim, Professor of Rheumatology at Fauji Foundation Hospital, Rawalpindi. Dr. Salim is a respected clinician and educator with experience in diagnosis and management of rheumatological disorders. He will be speaking on applications and limitations of musculoskeletal ultrasound.
As musculoskeletal ultrasound continues to evolve as a vital tool in rheumatology practice, understanding both its strengths and its boundaries is essential for accurate and responsible clinical use. Please join me in welcoming Dr. Babur Salim to share his insights.
Thank you, ladies and gentlemen. Thank you for the very kind introduction. Well, I'll be talking about the applications and limitations of musculoskeletal ultrasound. I can see a few of my students, so for them it is going to be an old presentation, but for the rest of the people it's going to be probably the new one. And well, we all know now that musculoskeletal ultrasound is important. I remember back in 2013 when I started musculoskeletal ultrasound in Pakistan, I used to ask everyone, all of my seniors, many people, but most of the people would be saying that there is no use of musculoskeletal ultrasound. And probably it's all clinical. Musculoskeletal ultrasound does not have any role in diagnosing rheumatic diseases. But I was really confused that if it does not have any role, then why the new articles and why the guidelines and why this stuff is coming up with some kind of addition of musculoskeletal ultrasound everywhere. So it was a very difficult challenge to do starting musculoskeletal ultrasound in Pakistan. So wherever I used to go, that I want to learn musculoskeletal ultrasound, from the radiologist, they used to say that, why don't you come and we both can learn from each other. And I was like, this is not the right answer, because hitting trials, maybe they're in the right direction, maybe in the wrong direction, that is the right pathway. So I got the opportunity to do the endorsed ULAR courses. Then they started back in 2014, and then basic course, intermediate course, and advanced, then teach the trainers ULAR courses. And after that, I had the plan that I got so much of the difficulties in learning, because going from Pakistan to another country to learn all these things and then coming back and applying it, and then doing an online course which used to fail because there was no ultrasound machine. So these were the challenges. Then once I had a mission that once if I am going to learn this kind of thing, I am going to spread this knowledge to each and every person who is from rheumatology community and also from the non-rheumatologists. So we have started teaching, making workshops, and we have Sabah sitting here, and she's the second person who started musculoskeletal ultrasound from our department. And then we frequently started the musculoskeletal ultrasound workshops. This is how the things went well. And now I know what are the applications and limitations. So I'm going to talk about the benefits and applications of musculoskeletal ultrasound. We are not musculoskeletal ultrasound specialists. We are rheumatology ultrasound specialists. So there is a difference between musculoskeletal ultrasonographer and a rheumatology ultrasound. So we need to think from that point of view. So that will make your life easy rather than thinking and searching for each fiber, each muscle, each tendon, and each nerve. That would be more difficult. So think as a rheumatologist and then use the musculoskeletal ultrasound. And I will definitely highlight few of the limitations, not much. So there are many benefits of musculoskeletal ultrasound, starting from that it's a non-invasive diagnostic tool, no radiation exposure. It's a bedside, you can do again and again. Multiple joints can be examined at the same time, unlikely an MRI. It is cost effective as compared to an MRI. And it is real-time dynamic. That is the most beautiful thing. It's not like just one picture. You can roll here and there, do the probes multiple times. So that's the beauty of musculoskeletal ultrasound. We can compare it with the other side as well. Again, unlikely an MRI. It's really impossible or really very cost if the patient is being asked to do an MRI of the both knees, because we have to compare it. That's not the logic. So in ultrasound, we can compare both the sides. There's no as such contraindications. And later on, once you'll start learning the basic skills, intermediate skills, then you'll be able to do how to do the guided procedures. And again, it is repeatable. You inject into the synovitis and call the patient after 2-3 days, and you'll see that probably the synovitis has improved by looking at into the doing an ultrasound. So I'll talk about a little bit about the rheumatologist perspective. This is my perspective as a rheumatologist, to use it as a diagnostic tool and as a therapeutic tool. If I see as the diagnostic tool, there are many, many benefits. You can pick up synovitis, dactylitis, tendinopathies, effusions, erosions, crystals, enthesophytes, nerve entrapments, and many more. So I'll talk a real-time case of 30 years old female. She presented with arthralgias, with early morning stiffness for around 30 minutes. And this has been happening for the last 2 months. There's no swelling. On examination, you could not find any evidence of synovitis. Serological tests are also negative. ESR is 20. So my question is from the audience, how many of you think that this is arthritis? Just the arthralgias, Morning stiffness is only 30 minutes. Examination, there's nothing. Serological test and acute phase reactants are also normal. How many of you think that this is arthritis? I think probably 1-2 hands, plus minus. But if, you're not sure it's inflammatory or non-inflammatory. You do an ultrasound and you see some signals around the MCP joints. Now, how many of you think that this is synovitis? I think that everyone would be very much sure that this is an inflammatory disease. So this was the disease evolution of the same patient. Initially, the patient was probably in the pre-arthritis stage, arthralgias with some PD signals. Day 1, after 1 month, the patient developed flexor tenosynovitis. After 3 months, there were some few pits on the nails. And after 6 months, the patient developed psoriasis. So after 1 month, the patient was unable to make the fist, and you did an ultrasound of the flexor tendons, and there are a lot of signals not only around the joint, but outside the joint as well. This is the joint area. You see a lot of signals outside the joint. So this is dactylitis. So another scenario is a 30 years old female has rheumatoid arthritis in clinical remission. She's perfectly fine. Disease activity score is in remission. Your next plan, would you continue the treatment? How many of you say that we should continue the treatment? How many of you think that let's taper the treatment? Okay. And how many of you think that we should up-titrate the treatment? So that's the tricky thing. So I use musculoskeletal ultrasound when I have a plan that the patient is in sustained remission. Should I taper the disease-modifying drug after the shared decision, or should I continue with it? So at that particular time, I always do an ultrasound. And if I see some signals, now I know that probably I'll continue or up-titrate the treatment, but I'm not going to taper this treatment. So that is one of the benefits of using musculoskeletal ultrasound. So this is, as a student of musculoskeletal ultrasound or rheumatology student, I always think that use ultrasound when your both eyes can't see. This was something which was being taught by the EULAR teachers. But later on, I started to learn that as a beginner, use ultrasound as your third eye when both eyes can see. So that's very important. The point is that when you see the patient, you know that this is synovitis. As a beginner, just put the probe and see how it looks like. Because as a beginner, you won't be able to pick the synovitis, but when both the eyes are confirmed, yes, this is synovitis, there is no doubt about it, just do an ultrasound. So that these two eyes match with the ultrasound. Later on, with the passage of time, when these two eyes can't see, you'll be so much perfect in picking up the synovitis that you're definitely going to pick when there is no synovitis by the visual symptoms, by the hands, and you're going to pick the ultrasound by using an ultrasound. So you know that EULAR recommendations as per the previous one, we have now the 2025 recommendations, but the reason I've added this is that one of the part by the EULAR 22 is that early erosions on X-ray. And that is one of the poor prognostic factor. We all know that one of the poor prognostic factors is that you find erosions on the X-ray. But the problem is that musculoskeletal ultrasound picks 46% versus 6.7% in early rheumatoid arthritis. So the sensitivity of picking the erosions by the musculoskeletal system is far high as compared to X-rays. However, the specificity is almost the same. These are how the erosions are being seen. It is a step-down erosion. Coming to crystals, as per the last recommendation by the ACR 2015, they have added the ultrasound as one of the diagnostic tool in picking the double contour sign. I won't go into the detail, but the sensitivity is of picking the double contour sign is around 70% and with a specificity of around 80 to 90%. And if you talk about the CPPD crystals, the sensitivity of picking the CPPD crystals by using an X-ray is only 50% as compared to musculoskeletal ultrasound. So though the specificity is comparable, but you need to know that if you are thinking of CPPD crystal, just do a scan, you can pick up the CPPD crystals more with a higher sensitivity as compared to X-rays. So there are many other things for which the musculoskeletal ultrasound can be used, including enthesitis. And I won't go into the detail. We are going to see all kind of these things, how the normal tendon looks like and how the abnormal tendon with tendinitis is going to. These are all the features. You can find anything which will show that this is probably the patient has tendinitis, no matter it's Doppler signals, calcification into zoophytes. These are examples of, these are some of the pictures of hypoechoic tendon, some calcification, active PD signals, and tendon thickening, etc., and many more. And definitely ultrasound can be used as a therapeutic implication. Dr. Sajjad is sitting here. He is a pain specialist and he's doing all the therapeutics related to ultrasound guided injections. This is how we inject. This is the first picture, is injecting the carpal tunnel syndrome around the carpal nerve, around the median nerve. The other one is subacromial bursitis. This is how the needle passes, and going into the black part is the fluid. So talking about the limitations, I won't go into the detail because I don't want to make you guys upset and stay away from musculoskeletal ultrasound. So there are no as such limitations. There are a few which you should be aware of. Cost of the machine is an issue, but trust me, in Pakistan, India, Sri Lanka, Nepal, we can get refurbished machines and buy a good one, learn more and more, and after that, once you're expert, then try to buy a bigger and expensive one. It is operator dependent. No, everything is operator dependent. No matter it's a stethoscope or it's an echo, everything, even a car is an operator dependent. But the best thing is you have to train yourself by some registered courses like ULAR. Limited field of view is again an issue. Cannot penetrate bone. So that is an issue, but that again helps us to differentiate between many other things which look like white. Bone is white. So if you put a probe and you can see something down the white line, this is not bone because sound waves do not penetrate the bone. Some artifacts you need to know, like reverberations, anisotropies, posterior acoustic shadows. I'll just show some pictures. Sometimes when you pass a needle, there's a to and fro motion of the sound waves and producing some reverberations. This is one of the artifact. And similarly, acoustic shadows can be seen. You won't be able to see, you see a clean shadow behind the bone. But if it is not bone, for example, it is some kind of calcification, you see a dirty gray shadow, which is one of the partial acoustic shadows. Similarly, if there's a gas, you won't be able to see a clear image behind the white line. Anisotropy is one of the artifact, but we use it to differentiate it from the tendon from a bone, tendon from a nerve. It is particularly being used for a tendon. That is that if you move the probe like this, the color is going to change. This is the specific for tendon. Sometimes it is very difficult that when we do a scan, is it a tendon, is it a nerve? Just do the scan like that, and when the color is going to change, that means this is probably a tendon. It's not a nerve. So this last slide's benefits outweigh the limits. There are so many limitations. You don't have to look for the limitations. Just start doing it. It is definitely going to help you guys. Thank you very much.
Thank you, Dr. Babur Salim. Our next distinguished speaker is Professor Ahmed Abogamal, Professor at Al Zahra Hospital, Dubai, UAE. Professor Abogamal brings with him a wealth of clinical and teaching experience, particularly in musculoskeletal medicine. His session, titled Hand and Wrist Anatomy, focuses on one of the most intricate and clinically significant regions in rheumatology and ultrasound practice.
A sound understanding of anatomy is the foundation of accurate imaging and diagnosis, and his talk will set the stage for more advanced ultrasound applications to follow. Please join me in welcoming Dr. Ahmed Abogamal.
Assalamu alaikum. Happy to be here for the second year in sequence, and thanks for the invitation. Okay, so I've been assigned to, in the coming 20 minutes, to give you the wrist and the hand. So I backed all the information. I know this is a basic level, but I'll try to get the most benefit from the coming 20 minutes from my slides. Always, I would like to start with by the intention that why we are here today. I always come to remember the famous verse of Prophet Muhammad sallallahu alaihi wasallam that about deeds are by intention. I also reminding you that all of us are here to be a better rheumatologist that can serve our patients better and help their pain by understanding and practicing the skills of the ultrasound. And here is my disclosure, nothing here related to my slides. Here are representing the famous picture of Al-Azhar University teaching halls standing for more than 1,000 years and still functioning till today. If you have been in Cairo, so just have a look on this already famous hall of teaching for more than 1,000 years. So the agenda of my talk, very short segments covering the anatomy, what lesion to be seen, how to be seen them, and small highlights about the updates of the scoring of the lesions there. The anatomy of the hand, on the wrist we have already the most important articulation in the upper limb, which is the wrist joint, heavily involved in the wrist pain and different kinds of arthritis. It's the articulation between the radius and the ulna in one side and the proximal row of the carpal bone in one side. We have arranged two different rows already named from the lateral to the medial with the scaphoid, the leonate, the triquetrum, and the pisiform, forming the first proximal row. And the second row is the scaphoid from the lateral again, the trapezoid, trapezia, capitate, and the hamate, the most medial part, forming two rows of the carpal bone attached to or articulate with the metacarpal bones. Why is this important? Just to understand there is a different levels of articulations. We have the forearm carpal level and the intercarpal and the carbo-metacarpal. And this already arranged again from medial lateral side to be radiocarpal and ulnar carpal side. So as already an assessment of the rest, we have 6 at least joint recesses to be assessed based on the anatomical arrangements that we have. Radial carpal, we have the intercarpal and the carbo-metacarpal both at the ulnar and the radial sides. That's enough for anatomy, and we'll go for the lesions in make it more practical. So what you are expected to see on the wrist joints with ultrasound? Any insights from the floor? What kind of lesion you expect to see? Okay, good. What else? Okay, what else? This, okay, it's very nice. Okay, what else we can see in the wrist? Okay, I have 20 minutes, so I choose some of the lesions here. We have synovitis, which is most important for us as a rheumatologist. And next would come the bone erosions, as most of you said already. And we have the tenosynovitis and the joint effusion. Here are some definitions that we need to understand about synovitis. It appears as hypoechoic, and the ultrasound term, we are already naming the structures based on the range from the most black side, we call it hypoechoic, and the most bright side, we call it as hyperechoic or white lesions. And synovitis appears as hypoechoic or black lesions, intra-articular, that not displaced under your probe and sometimes showing positive Doppler signal, as we are seeing here. Different kind, you can see this is black lesion, intra-articular, and showing Doppler signals, sure this is a synovitis. And again, we can see the different lesion, intra-articular, showing Doppler signal, for sure this is an synovitis. The second lesion, which is the tendon, and ultrasound is superior to visualize the tendon, especially in the around the wrist, hand, and the ankle joints. And usually the tendon appears as bagged fibers, hyperechoic lines with hypoechoic backgrounds. And the superiority of ultrasound in the tendon assessment, that we can see the tendon on static and dynamic assessment, which is very important, even superior to the MRI assessment. And the inflammation here, we call it as tenosynovitis, as we can see in the grayscale. The thickening of the tendon wrapping or the synovial covering, which appears again as black, similar to the synovitis. And also we can see Doppler signal if there's an active synovitis or tenosynovitis of around the wrist. Again, some images corresponding to the definition. Coming to the second lesion common, which is the black lesion, which is a joint effusion, which appears as, again, intra-articular black or anechoic. And here we have to differentiate between the synovitis and the effusion by using the pressure of your probe to displace the fluid rather than the tissue, which is not poorly displaced, as a comparison or differentiation between them, especially on the basic level. So we have two black intra-articular, effusion in one side and synovitis in one side. The synovitis not already displaced under the probe and showing Doppler if it is active, while effusion can be displaced and never showing Doppler signal positive. Coming to the lesion, another lesion around the wrist, which is the bone. Bone is the most reflective part, appears as bright white because of reflection of most of the ultrasound waves back to the probe and the high acoustic impedance between the surrounding tissue. Here is the white line representing the bony surface. Two important lesions could be seen, which is call it as the minus lesion, which is the bone erosions, which appear as a step down cortical abnormality seen in two planes to be confirmed. We call it as the erosion or the minus lesion of the bone in bone erosions. And for sure, ultrasound is superior than the conventional X-ray in defining erosions around the MCPs in rheumatoid arthritis. And also the beauty of ultrasound, it can even differentiate between active erosion and inactive based on the presence of the Doppler signal. Another lesion which outgrosses, we call it as osteophyte, which is step-up abnormalities seen in two planes for confirmations. So how we can see this? We usually have to fulfill three important steps regarding the patient position, the planes of assessment, and the bony landmark as already for assessing of the wrist and the hand. You have the patient resting on the table make sure that the wrist, fingers, and forearm in the same line, looking for the hyperechoic line here representing the radius in the most left part of the image, with the first row of the carpal bone, usually the lunate, and the capitate at the end. And this hypoechoic black shadow represents the joint recess covered by the extensor digitorum, mostly tendon on from the superficial aspect. This is a corresponding movement of the probe from proximal to distal. As we said on the introduction, we have also to do the same on the ulnar side to assess the ulna and the trapezoid and the hamate side on the medial aspect. And in short axis scan, we are looking to see the compartment of the extensor tendon in different compartments seen in short axis plane. Here what we are doing, we came from the short axis, a little bit from proximal to distal, looking for the tubercle of Lister. If you follow this, the bone profile of the radius, when I go distal more, you can see the top of the mountain here, which is the Lister tubercle. Why is this important? Because it's already localizing the compartment on the medial side, which is the third compartment, and the second on the most lateral. Here is the third compartment containing one tendon for extensor pollicis longus, followed by the biggest compartment on the extensor. Here we have 5 tendons of two muscles, extensor digitorum and the extensor indicis, followed by the 5th compartment just between the ulna and the radius for the extensor digiti minimi, and in the most medial, the most important for us, the extensor carpi ulnaris tendon in a separate compartment. Going back to the Lister tubercle, we have here in a sloping edge, we have 2 tendons, the extensor carpi radialis longus and brevis, and the most lateral, the most common cause of pain around the wrist, which is the first extensor compartment for the extensor digitorum or the Dekervian compartment. Here's the first extensor compartment. We can see the tendon already crossing the fibers. We can see the 2 tendons of the abductor pollicis longus and extensor pollicis brevis. From the volar aspect, the most important is the tendons and the carpal tunnel. As already one of you said, the carpal tunnel syndrome, as we can already localize. The median nerve has already static properties. It is the most superficial structure of the carpal tunnel content and also have the black from inside. So If you compare the echogenicity of the nerve to the tendon, it's more black from the inside, surrounded by 9 tendons for 3 muscles, 4 for flexor digitorum superficialis, 4 for profundus, and 1 for the pollicis longus. In long axis, you can see the row of the carpal bones and the radius and the recess from the volar aspect, also covered by the flexor tendons, and the most superficial here is the median nerve, which is again black from inside in comparison to the tendon. Coming to the fingers, which is very important for us in assessment of the hand arthritis, and we can see here the head of the metacarpal and the proximal phalanx, and this echogenic structure represents the fat bed, which is present on the dorsal and the volar aspect, and the most superficial here is the linear structure representing the extensor tendon, and here representing the position of the examination. And again, from the volar aspect or palmar aspect, we have again the plate covered by flexor tendon, which is a very important site for inflammation for either tenosynovitis or trigger finger, and covered by the poly at the head of the metacarpal, the alpha poly, which is very important for us for trigger finger, tenosynovitis, and also for dactylitis in patients with psoriatic arthritis. Short axis scan, you can see the 2 layers of the tendon, flexor digitorum superficialis and profundus on the deeper images. And here again, this is dorsal scan assessing the PIB joints. And the most important part that here, the recess here usually appears as a slit line pointing to the proximal side, and mostly there is no extension on the other distal side. In assessment of the flexor side from the volar scan, we have the volar plate again, and the head of the proximal phalanx and the middle phalanx in between, and the joint recess covered by the flexor tendon with, again, the poly on the most top superficial side. This is one of the important slides in assessment of the finger, which is the DIB region, because DIB complex is already involved in different diseases, especially between psoriatic arthritis and the osteoarthritis. That here I'm highlighting here the complex area here. We can see this is the DIB joints, and the recess point to the proximal, as I said, only slit recess on one side, and we have the extensor tendon, and its attachment here, consider one of the encystial part could be inflamed in inflammatory encystitis. And again, if you go more distal, we can see this is the nail with the nail bed and the nail poly, which is one also of the earliest part of inflamed in nail psoriasis and also in psoriatic arthritis as a part of encystitis. All of this complex is a part of the pain around the DIB region and can be appreciated by the ultrasound scan. From the volar aspect, again, we have encystial part as the attachments of the capsule area and the flexor tendon, and this is again the joint recess pointing towards the proximal side. The value of ultrasound also, you can examine the second and the fifth MCP from the either lateral and medial side to have an important view of the bone profile looking for erosion as a common site in inflammatory arthritis. And finally, this position, you can appreciate the hyaline cartilage over the head of the MCPs. I'm here highlighting the position. If you, in a real assessment, you can see the patient resting on in the table, okay, in one position, and if you can look here on assessment with the probe already. This is a corresponding image that we can see the bone profile of the radius, and we can see the first joint recess between the radius and the carpal bone. In long axis scan and with continuation, we can see the intercarpal joint recess, and this is the radial side, and also will be repeated on the other side for the assessment. For the small joint assessment, it's almost the same position as we already presented on the slides. We'll just highlight the corresponding image because of the time. This is a typical position of the probe, and the corresponding image you can see the shaft of the metacarpal and the head with the articulation representing here in the real assessment. Small slides about the scoring, because scoring is very important when you found any abnormalities, the most important for synovitis. And we have the last update from the OMRAC 2018 regarding the scoring for small joints of the hand for arthritis. And here is a cartoon representing the bony landmarks with this the joint recess. With this represents the fat pad obliterating the joint recess. If we have a synovitis, which is here in light blue, contained within the bony landmark, we call it as grade 1. And if it is already exceeding the bony landmark, we call it as grade 2. And if there is a convexity with extension to the shaft of the bone, we call it as grade 3 in grayscale. In Doppler, we are looking for the red colors. If there is no red colors at all, we call it as grade 0. And if we have 3 dots already, we call it as grade 1, or at least 2 confluent or 1 confluent signal, we call it as grade 1. And if it has more than that, less than 50%, we call it as grade 2. And if it is more than 50%, we call it as grade 3. This is a table corresponding that we said already in the assessment of the synovitis. And here is the corresponding images. You can go for the reference. Another scoring for the hyaline cartilage, which is also part of the important assessment of the osteoarthritis. We have the Anna Maria assessment score based on the cartilage thickness and the focal locking and partial or complete loss of the cartilage with irregularities. And the OMRAC defines this based on 4 important parameters, which is the echogenicity of the cartilage, the focal thinning and irregularities on top or bottom, and loss of sharpness of the hyaline cartilage. Here, one slide about the definition of the hyaline cartilage that appear as totally anechoic or hypoechoic with sharp demarcation from the synovial side. You can differentiate the cartilage clearly from the synovial side and again from the deeper side from the bone. This is definition of the normal hyaline cartilage. So normal, this is grade 0, and one, if there is loss of the homogeneous anechogenicity of the structure with or without focal thinning or irregularities, is grade 1. If you have already loss of the echogenicity with irregularities, we call it as grade 2, and grade 3 for focal thinning, either focal or complete thinning of the cartilage. And here is the corresponding images from the OMRAC scoring for hyaline cartilage loss of the hand. One last scoring for the hyaline cartilage about the rheumatoid arthritis, about the normal cartilage for grade 0, 1 for the minimal change, and grade 2 for severe cartilage loss. For the erosion, I will just highlight the Skodler assessment scoring, which one of the easy to be applied, and 0 for normal, and 1 for fine irregularities, was not big enough to be fulfill the definition of erosions, and grade 2 for the typical erosions, and grade 3 for the massive bone cortical collapse. Here is most of my slides, and looking for your questions, and I think we have time during the practical session. Thank you. Yes, we have a training program already with the ULAR covering the basic level, intermediate, and advanced. So this is a structured course to cover all the objectives for each joint as per the ULAR guidelines. I hope so, but already we are working on that. I think the APLAR working on this, doing once every 2 years or yearly course with the APLAR. And in our side in Dubai, we are doing this also every year in the first weekend of October, covering basic and intermediate level. Okay, thank you.
It's now time to shift from theory to practice. We invite all delegates to head towards the hands-on training stations for live demonstrations. Our expert instructors will be available to guide you. So do make most of this interactive learning session.
I request our participants to move to their respective stations according to the groups displayed earlier. In case of any queries, our usher will be here to assist you all.
Thank you.